for anyone that knows Dr. Safford and I, there's always more to talk about than there is time. So let me just start with a few announcements. CMEs and CEUs are available today. You can receive up to 2 credits, 1 credit for physicians or 2 hours of continuing ed for behavioral health providers. Certificates will be handed out at the end of the meeting. And those of you receiving AMA PRA Category 1 credits, your evaluation will come to you via email. So please be sure to take the time to complete those if you want continuing education credits. Also, another announcement, House Bill 4143 passed in the last legislation that is mandating prescribing providers to enroll in the PDNP. For those of you that have not enrolled, Erin, raise your hand. Yes, she can help you through that process if you need assistance doing that. Our next integrated care collaborative will be December 4th, and that one focuses on implementing the collaborative care model. The collaborative care model is embedding psychiatrists, consulting psychiatrists into the primary care setting. For those of you that don't know, and it's a really exciting opportunity for us to have Dr. Rainey, who is a subject matter expert in the field. Next, they kind of left it to Scott and I to ad-lib our introductions for each other. I will start with, I am a walker and a talker, and I have a broken hand, so if you see danger in my future, please alert me right away, because clearly I can't stay upright. That is a challenge for me. So I've had the pleasure of working with Dr. Safford for 6 years, almost 7 years. So he has, that means he has 7 years experience in the integrated care space. Yes. He has a doctoral degree from Temple University. Temple University, yes. Yeah, I know. I've had the pleasure of working with him on embedding algorithms for chronic medical conditions in the primary care arena. For his entire time in working in primary care, he is employed full-time as an embedded psychologist for St. Charles Family Care in Bend.
All right, I'm Scott Safford. This is Kim Swanson. As she mentioned, we worked together for a long time. We were the first wave of folks working for St. Charles when they created their embedded behavioral health consultant model, and we spent a lot of our first few years developing programs of care and figure out how to make all this work as best we can, kind of muddling along. And so it's been a pleasure working with her. She's very knowledgeable. Her education and training goes back to, she started in nursing. She's, her entire graduate training was in integrative care of some sort or another. She went to Loma Linda.
That's where I did
That's
my
postdoc.
final residency.
Dang it, it's like a memory test. I didn't know we were going to introduce each other. So she is now the director of behavioral health at Mosaic, and I'm sure she's doing great things there. And we're going to take it from there.
I want to thank Erin and Kelsey today. There are our helpers that sort of make this all run in the background. I also want to thank Don Creech, who is our regional consultant, and Dr. Franz, who's not here today, but will thank him in absentia for his work on making the collaboratives a successful event. Scott and I have nothing to disclose. We're relentless do-gooders that volunteer our time to give knowledge to anybody who's willing to listen to it. So we have nothing to disclose. Our course objectives really are to describe the role and responsibility of behavioral health in chronic medical conditions, describe key behavioral health strategies to treat chronic conditions, including multi-morbid conditions, and describe key ways to improve coordination of care for patients with chronic conditions, including multi-morbid conditions. This list of what we hope you learn today is extensive. And hopefully you'll have some key takeaways for your practice or your organization. I will say team-based care involves more than a BHC. We could highlight lots of other team players today, but we're just going to focus on this one aspect of it for today. I feel like I need to start with a disclaimer. In the integrated care space, people are still figuring a lot of things out. So like these parachutes of team players came in, we didn't have a manual of instruction on how to use all of them efficiently. So there's lots of different ways. We're going to talk a lot about why you would do this, but the how you would implement this is going to be talked about today through Scott and my lens of experience, and also what brings joy to my work. But there's lots of different ways to implement how you would do this, and we'll talk a little bit about organizations that are doing it and some differences in the future. But let's start with a question. Why would you refer a patient with diabetes and no mental health issues to a behavioral health consultant? Why would you do that? And this is the part where you join in. And my team who has had to listen to me for over a year saying this again and again and again, feel free to give the answer. Yes. Likely the person has they have emotional issues. Okay. So the impact of the diagnosis, and they may have emotional issues. Shanda's just itching to go. Go, Shanda.
So we know that there's four specific areas that somebody with diabetes, in terms of being able to manage their chronic condition, it's really important, which is monitoring medication, diet, and exercise. So that's well, looking at a person's attitude, behavioral health, from their lifestyle, their choices, their beliefs. Yes.
Yes and yes. My mic is cutting out. Okay. Any other thoughts? Yeah.
They're going to make some huge changes in their life, their lifestyle, everything, their relationship with food, exercise, routine.
Yeah, disease, managing a lifelong chronic condition requires that the patient show up and participate and make some changes, right? And that's with or without without mental health issues. And for most people, that's hard work. Any other thoughts before I move on? Okay. So let's just dive into a little bit of background. This is a pie graph most of you are aware of. And if you're not, you are today. And when we look at this, this is really what helps us look at what contributes to any health outcome and how we think about how we deliver care. And I've spent my career living in the health behaviors. And I actually love living in that space. It's somewhere in between all of that other stuff, right? But look at that. What do you think? 30%. 30% of a health outcome lives in health behaviors. That's a substantial amount of the pie. And when we look at our social determinants of health, that's 40%. So if we can look at both things, we've influenced 70% of a health outcome. Where we spend a lot of our focus is in the clinical care delivery, but that's really only 10%, right? But if we can influence clinical care delivery and we can help with health behaviors and social determinants of health, then we have 80%. We can't do a lot about somebody's genes, but we can focus on the areas where we influence. And BACs live in that 30%. And if you're thinking of them from an optimal way, you're going to think of them from a health behavior standpoint. It's not this background is not a surprise to anybody, right? In the fact that it's a key challenge to serve people with chronic medical conditions in the primary care arena. There's a high prevalence of comorbid or multimorbid conditions. It's very rare where we see somebody, for example, with diabetes where they only have diabetes. They usually have some other chronic condition in which they are managing as well. And it's a challenge when we think about how we're treating chronic medical conditions in any of our arenas, not to get condition-centric. And it's really important to remember, like when we get condition-centric, then we have an overlap of services, right? So if we think about managing, for example, hypertension or diabetes, and depression, and we're not looking at the entire landscape, then we're deploying resources in our teams in a very inefficient way. And if we look at that from all of those, then we can deploy resources differently. It's not uncommon and when we get condition-centric, we get specialty-centric. So it's not uncommon for individuals who have multimorbid chronic medical conditions to have multiple specialists who may or may not be coordinating care very well, and that includes behavioral health, and several medications on which we're asking them to manage. So then the care management for that patient becomes even greater. The integrated team-based approaches have added resources and workforce, and the goal of that is also to help save physicians time and costs, right? We're always looking towards the quadruple aim and how we deploy those resources. So why? Let's say why. Why would you consider using behavioral health as a key team player in chronic medical conditions? And number one, and the cornerstone of success in any chronic medical condition is self-management. Chronic disease management does not happen within the four walls of your office. It happens in their life. And what do we know about self-management? Well, we know that our patients aren't that great at it. If you send them to a self-management course, let's just say they have a new onset of diabetes and you send them to the diabetes course, the research is fairly robust. They will self-manage for 6 months and then they will stop. And then what? That's consistent. That's happened again, been replicated again and again. And unhealthy behaviors accounts for as much as 40% of premature deaths in the United States, whereas deficiencies in healthcare delivery only account for 10%. So, so we're looking at smoking, poor diet, lifestyle changes, and approximately 30 to 40% of success in treating a chronic medical condition is really reliant on the patient taking your message home and doing what they need to do at home. And how well do we monitor self-management? Right? If we're really, and this isn't a part where we can ask you to invite you in, but just think of a grade for yourself, A, B, C, D, or F. How well are you monitoring self-management? What do you ask? And then if you find out, what do you do? I would argue we don't do the best at self-management and looking at adherence in that. And patients' health education. You can't self-manage unless you know what to do, right? So the underpinnings of ongoing education in self-management is a cornerstone, and this is something BHCs do very routinely. And so all chronic medical conditions require that patients have knowledge regarding anything regarding their condition or conditions and how they overlap or don't. Nutrition, exercise, self-monitoring, medications, medication adherence, even in the absence of symptoms, and identifying and responding to psychosocial contributors to chronic disease management. So that cuts across all conditions. And lifestyle. Every chronic medical condition requires lifestyle modification. And I would say that lifestyle or behavioral medicine is the medicine that is the essential package for optimal health. And so we look at BHCs through the lens of behavioral medicine in this context, right? And so behavioral medicine is a field that's concerned with the integration of behavioral and biomedical science. So it's the marriage of the two, and primary care and integrated health is the perfect space for that to happen. So, and in lifestyle medicine, we're going to look at diet, and we're going to look at physical activity, sleep. Sleep is huge in our in that arena.
So another area that we look at within behavioral medicine is looking at stress management. And this is an interesting area. A lot of times a patient with a chronic health condition will get referred to me because of their medical condition, and I'll start talking to them about stress management, and their reaction is, well, I'm not anxious, right? And so really we have to look at what do we mean by stress. Stress is not just psychological. When I think of stress, I think of multiple factors. There's external stressors, environmental stressors, there's physiological stressors. If you have chronic pain, your body is in a physiological stress response. If you have the flu, your body is reacting in a stress response manner. There is also emotional, psychological stressors, anxiety, depression, things like that, but that's not the be all and end all of what we mean by stress. So from a behavioral medicine, lifestyle medicine standpoint, when we're talking about adaptive stress management, we're talking about more than just psychology. And one of the models that we look at is Hans Seeley was an endocrinologist, a physician who developed this general adaptation syndrome model of stress and how we respond to it, particularly chronic stress. Think about the patients that you work with and how many of them are facing various life stressors of various sorts. And you can see how this model portrays how the body responds to chronic stress. So initially the body rallies to react. So for example, let's say you have a presentation to give. If you're not motivated to do it, you don't prepare for it, right? If you have optimal activation, which is what stress does, is it activates us to respond, you're gonna do better. But if you're overwhelmed, your performance is gonna shut down. Right? So that's kind of that curve of how stress affects us psychologically, but it also affects us physiologically. If you're under a lot of stress, your immune system is going to be compromised. So really what we're looking at with this stress adaptation model is not just the psychology of it, not just the emotional reactions of it, but also how you respond physiologically, increases in cortisol levels, decreased immune system functioning. We do look at emotional factors. If somebody's under chronic stress, they're more likely to be anxious, depressed. But we also look at behaviors. How does somebody react to being under chronic stress? And a lot of people respond in what we call maladaptive ways, unhealthy responses to stress. So here's a list of what we call the negative stress cycle. And I'd say this is, all of us do this to some extent, right? Hopefully we don't do this to a detrimental extent, but most of us have done some of these things. You get home from work, it's stressed out, I'm gonna have a beer, right? Again, a beer may be okay. I'm gonna get home because I'm stressed out, I'm gonna have 10 beers, probably not a good idea. But we all, I think, engage in this. So I think this is another thing to think about, is this isn't just about these bad patients doing the bad things, right? I think we all do this to some extent, and we're trying to optimize adaptive functioning and reduce maladaptive functioning. So some of the things you see here, some people turn to substance use, some people use avoidant coping strategies, procrastination, the gamers who play video games all day long or watch TV, watch YouTube videos. I see patients all the time that do this. It's like, I got stuff I need to do, but I'm gonna spend all day zoning out watching TV or playing video games all day, things like that. Interesting thing, I skipped over smoking. I've always been fascinated by that one. Nicotine is a stimulant, but I have a lot of patients that say, well, I smoke to calm down. I've had patients that use methamphetamine that say the same thing. I'm really jacked up and I'm using meth because it helps me focus. So it's really kind of interesting that the choices we make aren't always in alignment with what we would think in terms of managing that effectively. Shopping, overspending, I've seen folks do that. Social isolation, that's another big one. A lot of times when people are stressed out, their world shrink down. They stop doing, they stop interacting, and that leads to a vicious cycle of oftentimes feeling worse because they feel disconnected. Keeping busy, that's the other end of the extreme. There's a lot of folks out there that their way of managing stress is to do and to do and to do and to do and to do, partially because if they slow down, they have to think about things and they have to think about their life and they have to think about their stressors. So they use activity as a coping strategy. Within the context of illness, I've seen patients that have had hip replacement surgery and now they can't keep busy. Now they're laid up for 6 weeks and now they really struggle with that because their coping strategy has been taken away. Emotional eating, overeating, sleeping too much, too little, are some other what we consider not healthy stress management strategies. When we look at a positive stress cycle, we're looking at how do we engage in a more adaptive coping strategies? What are the things that help us feel better? And these are things that I don't know what it is about human nature, but we forget these things. Think about times in your life where you've done something, it's like, you know, that was really fun. Why don't I do that more often? Again, that's something that I think a lot of us do. I think when we're in our life, our blinders go up and we forget to do the things that we know we need to do. But this is, you know, across the gamut, spending time with family and friends, eating healthy, making sure we're getting adequate sleep, not avoiding. Within looking at eating patterns, this is just one example of kind of a vicious cycle that we see, and kind of switching that into more of a positive cycle is with mindful eating. So if somebody has a tendency to stress eat, and whenever they get stressed, they're eating not because they're hungry, but because they're feeling emotionally distressed. And why do they do that? Because it releases endorphins, it activates their pleasure center of their brain. It feels good temporarily to eat pleasure foods. But what we try to do here to reduce the sequelae of that is really try to focus on more mindful eating. Thinking about why am I eating right now? What makes me feel better? When, what, how, why, how much, you know, all of these kind of things. We want to think about those things rather than going on autopilot and just eating because it's there. A couple other things that we look at from a behavioral medicine standpoint, we've already touched on these a little bit. These are some of the behavioral health factors that have some of the highest morbidity and mortality rates, or contribute to those, is smoking. So, you know, working on smoking cessation with folks who are smoking. There's all sorts of health risks associated with being obese or overweight. So working on weight management strategies, looking at safe drinking limits. And that's a tricky one. There's a lot of different research that comes out. There was a recent study that just came out that said there is no safe alcohol level. So I don't know what to make of that, because there's some studies saying that teetotalers are at greater risk of certain health consequences. Moderate drinkers are less at risk, but the fact of the matter is alcohol is a toxin. So it is, you know, what we want to try to do is maintain safe drinking levels and help patients even understand what that means. We live in a beer town. And so a lot of times what people's understanding of what safe drinking is based on their social cohort. So going to a bar and having 2 or 3 IPAs, which are, you know, 7 to 8% alcohol, all their friends do that, or maybe they feel like, well, that's okay because my friends drink more. And I've had that conversation a lot with patients. Like, well, we're not saying you're an alcoholic. That's not what this is about, because that's kind of how they see it. I'm not an alcoholic. I go and have 3 or 4 beers. I go home, I wake up, go to work. So I don't really see it as a problem. So really the conversation is about the physiological effects on the body of that over time. So the good news when we look at behavioral medicine is the healthcare field has made substantial strides in coming up with medications to address chronic health conditions. Think of all the medications we have for diabetes, you know, dozens of them. Think of medications for high blood pressure, for high cholesterol, for, you know, if you look at any kind of chronic medical condition, we have lots and lots of medications to try to treat that. We also live in a society where we are told that medications is the answer to a problem. And so the downside, the bad news is even though we've come up with good remedies from a medication standpoint, we really haven't done a great job of addressing those behavioral health issues that are underlying and contribute to it, and figuring out how to help maintain that motivation to engage in behavioral health management of those. I know folks that had high cholesterol, and so they start on a statin drug, and their cholesterol comes down. They're like, oh, I don't need to exercise, my cholesterol is okay. Still not necessarily the right answer there. So sometimes the medications addressing it, there's question about whether that really has the outcomes we're looking for. So still some work to do. Another area we work on in, for behavioral health consultants is this concept of non-adherence. And this means both medications. So you prescribe a medication. Does the patient continue on that medication, or do they discontinue? Do they take it regularly? Do they take it as prescribed? This has to do with behavioral recommendations. Hey, I would like you to exercise 30 minutes every day. You know, that would be a behavioral recommendation. And does the patient come back and say, yes, I did that? That's adherence. But also referrals. You refer out to a specialist, you refer out for further evaluation, you refer for labs, and does the patient follow up with that? So when we talk about non-adherence, we talk about this across the board. And historically, healthcare providers were kind of the folks that would tell the patient, well, this is what you need to do, and you go do it. And if they didn't do it, they were non-compliant. Right? So what is the meaning of compliance? It means you are choosing not to do the things I'm telling you to do. And that's why we've switched the language to this concept of adherence, because we're looking at, well, what are the variables that are involved? And I'll talk about that in just a moment. So some of the things we look at, so when we talk about medications, we really have to look at practical matters here. So does somebody have access to transportation? Can they get to the pharmacy to pick up their medication? We look at understanding communication with the provider. Do they understand the directions that the provider was given? Do they understand if they're told to take a medication, 2 pills twice a day? Do they understand what that means? Does that mean take 1 pill twice a day, or 2 pills twice a day, or 4 pills in the morning? So understanding the instructions becomes important. Did the medication actually end up at the pharmacy? So that's kind of a pharmacy issue. How many times has that happened where a patient calls up the clinic and said, well, I went to the pharmacy, they said the medication's not there. What happened to it? So it got lost in the EHR system, something happened. And so then they're like, well, I live out in Chemalt and I drove into Lapine to pick up my medication. It wasn't there. I'm not going back. Right? So there's practical variables here that really don't have to do just with the patient choosing not to be compliant with what you're recommending to them. This is some of the variables that we look at here. So one of the things we want to think about is non-adherence is really more the norm than the exception. Think about, again, I think it's helpful to look at our own lives. I mean, how many times have you been asked to do something by a healthcare provider and you didn't do it? We oftentimes hear that physicians make the worst patients, right? So your doc says, hey, go do this. Did you do it? Did you follow through? So again, we really want to take a move away from this concept of vilifying the patient and really looking at what are the variables involved, what are the barriers involved, what makes it difficult for them to do what you're asking them to do, so that we can try to problem solve with them. But this is one of the many reasons, one of the more common reasons why providers might refer somebody to behavioral health, because they're like, told this patient to do all this stuff and they're not doing it, fix them for me. Right? So I sometimes see that. So kind of in a schematic view, these are some of the variables we might want to look at from a treatment standpoint. So if somebody is not adherent to the treatment recommendations, what are some of the variables involved? Socioeconomic variables, can they afford the medication? I think that's a big factor for a lot of folks. So looking at healthcare team, healthcare system, is there a breakdown? So I talked about kind of going to the pharmacy to pick up a medication and it's not there. How about referrals? I put in a referral. I'm sitting around waiting for the specialist to call me to schedule. They never do. And so then I call the doc and what do I do? Well, it went there, so you need to call them. I call them, oh, we don't have it. So that's a breakdown in the healthcare system. Condition related, if somebody is dealing with a chronic health condition, sometimes it's hard for them to, depending on what the healthcare condition is, it's hard for them to engage in activities just because of the consequences of their health condition itself. So the health condition itself sometimes becomes a barrier. I've seen patients that will no-show or cancel medical appointments, and they'll say, because I wasn't feeling good. Like, well, that's why you go to the doctor, right? So again, there's a lot of variables here. Treatment-related side effects. If medication has a lot of side effects, from a provider's perspective, we might say, well, is the benefit outweigh the side effects? If you're getting all this benefit from this, you're getting better, but yeah, there's a few side effects. Whereas they may say, I don't like these side effects at all. I don't want any side effects. That may not be realistic. So part of this is also looking at knowledge and education about how medications work, what to expect from a treatment. We see this with behavioral recommendations. You recommend a behavioral change and they do it a couple times and it doesn't work. It's like, well, is that a reasonable expectation that you do something a couple times and all of a sudden it's better? So as behavioral health consultants, we are in a unique position because of our knowledge and training to try to problem solve these areas, figure out what the barriers are, what gets in the way of them adhering to whatever the treatment recommendations are, so we can help facilitate that. The other thing we look at is social factors, family factors that play a role in health management. Family cohesion is a variable. So if there is a lot of friction in a family, managing their diabetes may not be high on their priority list. Right? We talked about socioeconomic factors and affordability, things like that. Family stress, that doesn't necessarily mean that the family's in conflict, but if the family, let's say, husband loses his job, wife loses her job, and you're trying to deal with that, going to pick up your medications, taking your medications, making that call to the specialist, going into the lab to get your labs drawn may not be high on your priority list when you're trying to figure out, oh my gosh, what are we going to do to be able to afford food and keep a roof over our head? Cognitive appraisal, what is their understanding and how do they perceive their health condition? So for some folks, we have what's called catastrophic thinking. Oh my gosh, I've seen folks who diagnosed with diabetes, who they get the diagnosis and maybe they had a family member who died from complications of diabetes. Their reaction is, oh my gosh, I'm going to die in the next 5 years, because that's what happened to my uncle. So that becomes an overwhelming factor. And for some people, their response is maladaptive coping. They ignore it. I don't want to think about it. Right? I don't want to deal with it. But also looking at health literacy. What is an individual's understanding of how health works, how our bodies work, how medications work, how behavioral interventions work? I touched on that before. And you'd be surprised how people view and think about health functioning and whether that is consistent with how you view it. A simple example, some folks, and again, not to get controversial or anything, but just kind of a viewpoint, is some folks might say, well, prayer is what is going to help me the best. That's going to be much more effective for me to pray and to go to my church and have my church members pray for me than to take this medication. And so as healthcare providers, you could poo-poo that, or you could say, okay, well, how do I work with that? If that's their value system and their belief system, how do you work with that rather than saying, I can't work with this patient? The other thing we look at is solicitousness. Are you familiar with that term, what that means? Basically, that term refers to how does the family respond to their illness? So, simple example, child falls down and skins their knee. Oh my gosh, Susie, how you doing? Are you okay? Is everything okay? Does that hurt really bad? What can I do to help? Let me get you a candy, right? That's over solicitous response to injury. And so sometimes that's how family members respond to health crises, is they rally around it, they support it in not necessarily an adaptive way. They over support it, they over caretake. And it really, on one hand, it sometimes limits an individual's ability to engage in self-management because my family's going to take care of me. But also, sometimes we have negative reinforcement. I get a lot of attention if I'm sick. I get a lot of attention if I'm not doing well. Why would I want to manage my diabetes and have my wife ignore me again? Right here, I'm going in and out of the hospital because of DKA or whatever, and my family all wraps around me when that happens. So again, from a logic perspective, it's like, well, why would you want to put yourself through that? But don't undervalue the importance of social connectedness. And people will oftentimes do things that are not necessarily as adaptive as we want to acquire that. We also look at how does the family in general cope and problem solve. We are all influenced by our families to some extent. Sometimes we move away from the choices our family makes. Sometimes we align with the choices our family make. But if our family as a whole, it has kind of an avoidant coping strategy, family members diagnosed with diabetes or some other chronic health condition, and their solution is to ignore it and not talk to you about it, not support you about it because it's too distressing for the family members that you have a chronic health condition, they're overwhelmed by it, it's going to be much harder for you to manage it in that kind of scenario. Okay. The other thing we do as behavioral health consultants is we do have some expertise in mental health, hopefully, right? So that is a vital point. We don't want to focus on that, but that is still an important factor a role that we play. We help with assessment. We help with triaging, identifying what's going on. We know that when individuals with chronic health conditions, diabetes, chronic pain, what have you, also have a mental health condition, that it costs 46% more to treat that individual, right? So that's a large chunk. That's a large chunk, partially because they are dealing with other issues, partially because individuals who have mental health issues are less inclined to engage in adaptive coping strategies. They may be less adherent to treatment recommendations. So this is a vital component of managing chronic illness. It's not the only component. I think a strong argument can be made for referring, as we talked about earlier, somebody with a chronic health condition who has no mental health issue. Why do I believe that? Because as we talked about with those determinants of health, if 30% of it is behavioral health, it doesn't matter to me whether you have a mental health condition, your behavioral choices played a big chunk of a role in your chronic health condition, most likely. Right? I mean, certainly there's folks that have bad genetics and just like they exercise, they eat healthy, and they still develop chronic conditions. But I'd say that's not the majority of folks with chronic health conditions. But we do want to screen for these things. And a lot of times providers, physicians, advanced practice providers don't assess for these things, especially historically in kind of traditional medical settings. And a large part of that is time. I'm thinking of a number of years ago, a patient came in for a hospital follow-up with a broken hand. And simple condition, broken hand. And I asked the doc, I said, did you ask why or how they broke their hand? Never did. And they didn't have time. They had like 28, 30 patients that day, and it was a 15-minute hospital follow-up. And so I met with this patient. They got in a fight with their boyfriend, and she punched a wall and broke her hand. That's a psychosocial factor that's probably going to be an ongoing health issue down the road. But in that 15-minute appointment where you're just doing a hospital follow-up to check on the status of the broken hand, you may not take the time to find that out. And that's why collaborative work with your behavioral health consultant is so vital, because we'll catch things that you may not have the time to catch. The other factors that we look at are financial. So we look at financial and quality incentive components. And there's two sides to this. There's revenue generation. So this first slide is really looking at how can we help with revenue generation. A physician, an advanced practitioner, can only see X number of patients in a day. So their revenue generation is determined by how many patients they can see in a day. And if a patient is seeing, or a physician or provider is seeing a patient who has complex psychosocial issues, does that take more time or less time for that provider to see them? Usually takes a little bit more time, right? And so if you have a number of those folks in a day, you're going to get backlogged, right? You're scheduled for a 15-minute appointment. Your patient comes in, oh, I just broke up with my boyfriend and my car broke down and I might lose my job. Okay, well, I just wanted to check on your medications. And so that is an ideal time to say, let's bring in a behavioral health consultant. So we're going to focus on this, and we're going to bring in somebody who has some expertise in that area that could help you work through some issues related to that and come up with some solutions for that. And so in that process, it allows the provider to see more patients, which is increased revenue generation. If the behavioral health consultant is used effectively by that clinic, then they'll be able to see more providers. They'll be able to generate more revenue in addition to whatever revenue the behavioral health consultant generates seeing providers. So this is just looking at some studies and statistics that in a clinic without a behavioral health consultant, if they're gone for a day, that clinic might lose up to $1,000 a day in revenue generation, as one example. We also look at the flip side of this, looking at cost containment. So there's revenue generation, creating revenue, but we also look at cost containment. And so one of the things that we find is that when we have a behavioral health consultant, you're working collaboratively as a team with a primary care provider, that you're actually going to decrease utilization of more expensive resources, cutting down on ER visits, cutting down on the need for specialty referrals, things like that. If you're working on helping increase adherence to medication regimens, they're less likely to have complications from not taking their medications, which is one of the biggest predictors of why many people don't do well on medications. They just don't take them or don't take them as prescribed. And also this important component of reducing fragmentation, that when you have siloed care, you have people in different settings that aren't communicating well with each other, it's just harder to manage chronic health conditions. That model works relatively well for acute issues, where you send them to a specialist and they fix the problem and send them back to you. But when you're dealing with chronic health conditions, you really need a lot of collaboration and coordination of care. And when you're in the same setting and you have a behavioral health consultant that can help facilitate that, I think it helps quite a bit. Okay. Yeah. You want me to do this one, or do you want to do it? Okay.
Wonky transitions. Still early. I think when we add resources into our medical settings, it also helps providers in that space be more satisfied with their work. And I think that goes both ways. One of the greatest parts of satisfaction in my work is working within medical teams my entire career, which is actually longer than I want to say out loud at this point. So I think it really increases job satisfaction for all of the providers in the team, and we learn from each other. This is our last slide, and we're going to get out of background, but there's lots of really good examples of integrated care centers of excellence that really use team-based care in a really effective and efficient manner, where they're using BHCs routinely in physical health conditions, and how they do it varies across a lot of these settings. So it's not really where they're getting hung up in the how, it's the why. And this is not meant to be all-inclusive, but here's some examples if you get curious and you want to look up and see what they've got going on in their integrated care space. These are just a few examples you can look up. Okay, this is another part. Here's the quiz. This is the part where you get to join in again. What is team-based care? A, B, or C? It is A and B, and it's a little bit of C right now, and we'll talk about that. But thanks, that's a totally honest response that I totally appreciate. Thank you. All right. I think we're in this stage of rethinking what it is, right? We're not really structured in a team-based way. And by the way, it's A, or at least you hope it is. I can't speak for you. I mean, I think I got in early, and I got in some really innovative training spaces that trained me to be a team member. How many of you can say that? Yeah, so we don't, I'd say that's 5% of the room raise their hand. So we're not necessarily even trained to think about how to be a team member and how do we function as a member of that team. So I think part of that restructuring is training and thinking. And now we're having to go back and we're having to rethink how we engage with our teams and how do we be an effective team member. And the current model really still is referral based, where we're still relying on our primary care providers to really direct the care. And as the care gets bigger and bigger and bigger, that doesn't lend to much thinking time of how I'm going to reframe myself on how I'm going to be on this team. And it's probably not the most efficient use of resources in a team-based care setting. And I'm going to tell you my experience. And this is like a direct quote. Well, they're not Kim bad yet, right? They're not bad enough to see Kim. I don't want you to think that way. I actually don't. I want you, I want every patient who has something that's worthy of my time to get my time. But if we structure our time around a referral-based setting, you're not going to think that way because you don't have time to think that way, right? And really, we want that patient-centered medical home to really be restructured by that, right? We want it to be fluid, effective, and not rely on thinking time. And we want convenient access. We want focus on wellness and disease prevention. We want support for resources and self-management, which is the cornerstone of health for anybody. I would argue self-management is the cornerstone of wellness as well. Wellness doesn't happen by accident. You have to do something to get it. And I would also say we want our care to be coordinated and we want to continue to grow and perform and improve. Like we're all just figuring this out. What makes team-based care as effective is an absolutely loaded question. And interestingly, last week, the American Psychological Association has a publication called The Monitor, and it goes out to people who are members monthly. And it happened to have this really great article listed on team-based care. So of course I dived in because I love, like I'm the geek's geek and I read lots of stuff on team-based care. So what is the secret sauce? What do you think the secret sauce of team-based care is? This is where I'm inviting you again. I know it's before 8 and you're under caffeinated, but let's go there. What do you think makes team-based care effective? What's its secret sauce? Communication. That's one. Yep. Trust. What else? Commitment to value. I'm going to just dive into we don't know. We think it's the intervention of the team itself. So they're just looking at this and they're saying, okay, so let's look at teams that have got this. And, you know, medicine is sort of new to this, right? The military has been doing team-based work for a long time. And when we look at what's effective in teams, you've got task work, right? That the team has to do in order to achieve a goal, like expert screenings, everybody's favorite topic at 8:50 or 7:50 in the morning. That's a task work and how you decide how to deploy the team. But here's the secret sauce. It's a shared mindset, shared value. Now think about how we have structured teams now. How do you get to that shared mindset and value in thinking space about how you're going to work together? We haven't done that great of a job in creating that, right? We haven't trained people to do that. And when we started adding resources to primary care, one of the most exciting parts of my career is watching that happen. We didn't really structure your thinking time of how I'm going to use my team in the most effective way. But that is the secret sauce, and that's where we have to go. The underpinnings are shared mindset and trust. That is the secret sauce of effective team-based care. You can't underestimate the importance of the other parts of the team, right? Operationally, our operations teams have really focused on supporting MA provider teams. And it's a big jump for them to figure out how to support multiple disciplines within a setting because it's not so easy when we think about the rules and regulations of those different practices and what goes into caring for those. So in order for us to be really effective teams with a shared mindset and trust, you have to have infrastructure around all of the practices in order to make that effective and work. So that's what makes it sustainable, and that's what offers continuous quality improvement, and it really leads to satisfaction across that. You also need engaged leadership. This is a practice change. It is a mindset change, but it's a practice change, and you need informed leaders that are really in the game, really helping you with all of the elements of the practice change. What happens a lot of times without those things is it feels like you're Prometheus rolling the boulder up the hill. And it gets a lot of hard work, regardless of the provider type. So we have different types of teams. We have multidisciplinary, interdisciplinary, and transdisciplinary. Transdisciplinary is new. It's sort of who's heard of it before? Raise your hand. Okay, we got 2 hands in the room, so this is new. So we started off with multidisciplinary teams, and what that assumes in the team-based care arena is that there's a hierarchy, and that's much like that picture I showed you earlier, where the PCP is really making the decisions on a referral base to direct the care. And so what happens is the results get brought together in the end, but there's not really an assumption in a multidisciplinary setting that teams are actually going to work together. There's still an underpinning assumption of siloed care. And then we moved into interdisciplinary care, and if this was in a picture up here, it would be a graph. And each of the disciplines would have their pie, and it would not assume hierarchy, and every discipline had equal value in their opinion, but it really doesn't, and it's an improvement. And it has some important highlights that we've added to the care, but it doesn't assume the teams are going to work together. There's still an underpinning of siloedness in that interdisciplinary approach. Transdisciplinary is interdisciplinary like on steroids. And what that implies is that everybody is cross-trained enough in somebody else's job that we can talk each other's language and do a little bit of each other's work. That's groovy stuff, right? And so so everybody on that team is still accountable for the care. But we know enough about what you're doing and enough in your profession that from my lens, I can talk about it. And there are times in a transdisciplinary team, I'll give you an example, where only 1 or 2 are really taking charge, and then they step out and then the other team members come in. So think of somebody who is a high utilizer of the health system, and they have multi-morbid issues coming on. So the 2 people that might step up into that initially might be, for example, an RNCC and a CHW, right? And the other team members have a pulse of what's happening, but they're really in charge of trying to figure out what that pattern of utilization is. And then they're making deployments based on what they see with other team members, right? So that's a great example. Or somebody in a transdisciplinary setting, you know, you'll have somebody step up, you're kind of eyeing a person who is not doing what they should be doing with diabetes. And so the RNCC and the BHC step up and they're leading the team. And then once they figure out those issues, they back off. And then but everybody has a pulse on it. Does that make sense? Is this you? Oh, still me. Okay. So this is just another sort of experience of looking at where we are today and where we just need to go, right? And so, you know, it's new to primary care to have this idea that we need to know the disposition of all of our patients on our panel at all times versus just the ones that are coming in. But that's what we're tasked with. And we also need to have a proactive care plan and engage in more prevention and wellness than we did historically. And care is standardized and evidence-based to some degree, although there's some local variances of control or differences of opinion of deploying evidence-based. We measure quality and we make rapid changes based on that. That's very new. We have a prepared team of individuals that coordinate and participate in the patient's care. And we track consultations, ED, hospital, and the team works at the top of their license. Every team member is working at the top of their license in order to provide optimal care. So this is just a picture of what we were talking about before. And if you look at this overlap, again, just focusing on the BHC, we have many team members that are equally as important, is the health behavior is where we share the space, right? And medications go across all of the disciplines as well. But if we're sharing the space and buying in with each other in that transdisciplinary approach, we both approach health behaviors, right? From very different lenses, but equally important.
Okay, so I'm going to pick up and talk about what is the role of behavioral health consultant within this transdisciplinary or multidisciplinary model. How do we make this work? What is our job? So we just want to try to clarify that one of the first principles, we want to look at the principles of what a behavioral health consultant does. And one of the first principles that are part of their job is identifying, treating, triaging, and managing primary care patients, broadly defined. So that means medical conditions and or mental health conditions. So this isn't, again, we don't want this siloing where, okay, this patient has mental health issues, let's send them to the behavioral health consultant. We want to go beyond that. They function as a core member of the team. So again, we don't want siloed care. We want them to be integral to the treatment management process. And we really want to focus on population-based care philosophy. This is very different from traditional mental health where it's very patient-centered. You have your set of patients that you see and your focus is on treating that one patient until completion of treatment, whatever that might be. From a population health-based model, if you're familiar with that term, you're really looking at your patient population as all of the patients in the clinic, and you're trying to improve the health of all of them. And so you try to figure out what role you can play in improving health functioning across the board. There's always going to be that 5% that use 80% of the resources, and oftentimes I've had physicians that will refer that patient to me. They're train wrecks. I'm not going to have much success either. I'm more than willing to help the physician manage this, because part of it, I was talking to a physician about this the other day. Part of what I was helping manage was her distress and frustration about dealing with multiple train wrecks throughout the day. So it's like, okay, yeah, I'm here to help you manage contain that distress about dealing with somebody who may not make a lot of progress. And I'm going to fight the good fight. I'm going to try to help with that. But there is still, roughly 5% of folks that it's really hard to budge the dial a little bit. So when we look at population health, we don't want to just focus on those extreme cases. We want to look at the whole population. And we'll talk about some of the metrics that we look at in just a little while and try to manage that. And then we also seek to enhance delivery of behavioral health in terms of folks who do need more traditional mental health services, so we could help facilitate that process. There's plenty of research showing that when a physician says, oh, you need specialty care, you're kind of a long-term therapy client, and they provide contact numbers for that patient. How many of those patients actually follow up on that? Right? Some studies say less than 50%. Right? And so as a behavioral health consultant, and again, training and working with the healthcare providers to understand that it's helpful for them to see the behavioral health consultant, even if you believe they need traditional mental health, because we can help facilitate that process. We could help coordinate communication with those folks. Because a lot of times when folks go to traditional mental health, goes into a black box. You never hear what's going on there. And there's reasons for that. People want to protect their confidentiality and their thought process on why they want to do that. They may not want their physician to know what's going on with kind of their psychosocial issues. So I've certainly ran into that, but we can try to help coordinate that communication to make sure we're all on the same page. We could try to make sure that they are following up with their outpatient therapist. So we play a vital role in that coordination of care with mental health. When we look at these models, we want to look at where do you fall along the spectrum. So Kim was talking about these different models of integrated care, and the spectrum really starts clear at the left-hand side over there of really no integration. So this is, for example, there's physicians, think old school model, physicians or providers who have a core group of therapists that they trust and value. And I refer to those folks because I know who they are, I know they do good work, I know they give feedback to me, and that would be kind of a referral-based model where there's some communication, but not really collaboration of care. You advance to more of a co-located model where you have a provider who's in the same clinic, but they may be practicing independently as a mental health care provider. So they're not a behavioral health consultant. I've seen situations where the behavioral health consultant is treated as a co-located mental health provider. Again, not ideal from an integrated care model. And then all the way up to more integrated models where there's collaboration, they're working together on developing a treatment program, a care program, so that they're working together, communicating about what each person is doing and working with that patient and coming up with a game plan for being proactive at responding to what they're going to be coming to next, rather than just responding to when they show up that day. So we want to look at who are behavioral health consultants. What is the training that is required of them? Usually behavioral health consultants fall into one of these three categories: a licensed professional counselor, LPC, a licensed social worker, LCSW, or a licensed psychologist, either a PhD or PsyD. And all of these folks have similar trainings in some respects. It used to be when these training programs were developed, they had kind of different roles in terms of the types of patients they saw in kind of traditional mental health model. But one of the things that I've seen is over time, there's a lot more blurring of those much of the training that a social worker might have may be very similar to what a psychologist has, maybe fewer years, but the training might be the same. And across the board like that. It used to be that PhD was more research focused, PsyD was more clinically focused. I've certainly seen plenty of people with a PsyD degree that had to do a research-based doctoral dissertation. So again, a lot more blurring in terms of the differentiation of these folks, but they all have kind of essential training in evaluating behavioral health needs, in figuring out what the behavioral health history is, assessing readiness for change, what is their willingness to engage in behavioral changes, identifying what the treatment preferences are. I mean, that's an important point too. We may have all these great ideas as behavioral health consultants of what we think might help a patient, but that's tricky if we see a patient that they're wanting a medication and that's their treatment preference. If you have a strong argument for why that might not be a good choice, you may work on trying to modify that health belief. But there's plenty of conditions where, especially mental health conditions, where medications and behavioral interventions are about equally effective. You may want to discuss that with the patient. What's their personal preference? I'd say the same thing is also true for the physician. We don't want to assume that medications is what patients want. There's certainly situations where a patient would prefer to have behavioral health interventions. But if you're a prescriber, that's what you do is prescribe. And so sometimes you get locked into that pattern of addressing a problem. And that's where integrated care can help kind of circumvent that, because you have other eyes on the situation. Consulting with the primary care providers on patient treatment, so you're working collaboratively as a team, and intervening to address the problems in overall health and wellness. And it's really in all of the various training, behavioral health providers with various trainings could do all of these things. Then we want to look at, what does a behavioral health consultant do? What does their day look like? What are the range of roles that they play? And so I'm just going to define some terms here. So we look at what's called a meet and greet, if you're not familiar with that term. Basically, one of the important things about being a behavioral health consultant is you want to be flexible, you want to be available, and you want to be fast-paced. The primary care setting is very fast-paced. We talk about kind of what is it, the fern and a cot, so couch and a cot, couch and a fern, that's what it is. In traditional practice where somebody comes in and you have an hour that you're working with them. In primary care, it doesn't work that way. You see the patients in the physician exam rooms, oftentimes, or the provider exam rooms. Very fast-paced. You want to be available at that time. Certainly you have patients scheduled. So sometimes we may just do a meet and greet. And this may happen because you have somebody that you're going to see. It could be because and I've seen a situation where the physician says, hey, I'd like you to see the behavioral health consultant. Oh, I can't, I got to get back to work. Well, can you meet with them for 2 minutes? And you go in and you describe what your role as a behavioral health consultant, what you do, how you're different from traditional mental health, how you might help in their care, and then giving them some information, and they can schedule on their way out the door. And they're trying to do some research now on whether that increases follow-up in terms of people's engagement with behavioral health consultant. But that seems to be, at least from a theoretical model at this point, a very valuable component of behavioral health treatment, behavioral health consulting. On-demand, same-day health consultation. Again, you want to be available when you're needed. We oftentimes do same-day warm handoffs. A physician sees somebody, hey, they identify the issue. Hey, can you come see this person? Are you available to step in the room when we're done? And ideally, the answer is yes. But again, that's not always an option. Another role that we play is consultation. So sometimes we don't even necessarily see the patient. The doc has been seeing something. I'm not really sure what to do here. Maybe it's a situation where the patient is declining to see the behavioral health consultant. Can you give me some ideas about what I might try to do as a provider? This is where transdisciplinary care becomes important. So, for example, if I'm working with somebody on sleep management, and I have some training and expertise in working on sleep management, CBTI or behavioral interventions for sleep, if a patient's not willing to see me, that's certainly something a physician or a nurse practitioner or advanced care practitioner can do as well. Right? So I could do a consult with some interventions on that, especially in a transdisciplinary model where we're able to kind of cross-cover what we do. The first contact, billing contact is an initial consultation. This is where you assess, a lot of times doing kind of a functional assessment. What are the variables and factors that contribute to their health issue? What are the barriers that make it difficult for them to manage their health issue? And trying to help them problem solve that. We usually want to keep those appointments between 15 to 30 minutes, which is tough. I've talked to folks who do traditional mental health, and they sometimes look at this, well, this is therapy light, right? I can tell you from being in both worlds in the past and transition to this position, it's harder to do this work in 30 minutes than it is to do it in an hour. It's much harder. So you have to be pretty tight on being able to do this. And I admit, I'm not an expert at this. Sometimes my initial appointments are 40 minutes, but I try my best to get it down to 30 if I can. But that's kind of the model is 30-minute consult, gather as much information as you can at variables that are contributing to condition, coming up with a behavioral plan of action, feedback to the physician about, sometimes we make medication recommendations, we make behavioral recommendations to the patient, send them on their way. Self-management, we want to give them things that they could do at home. As we talked about before, you may see a patient for 30 minutes a month, right? That's not going to necessarily be the be-all and end-all of them managing their health conditions. So that's self-management is vital, and that's really what we try to focus on in that intervention. We do a behavioral health follow-up. Depending on the model, how frequently you see a patient, how many times you see a patient varies. Sometimes it's between 1 and 5 appointments. Right? So you're giving them a set of tools, sending them on their way to go forth and try to manage that with self-management. But we do have follow-ups, and those follow-ups could be scheduled as a back-to-back. I see you're coming back in to see your physician in a month for medication follow-up. Why don't we go ahead and schedule follow up back to back, so you're seeing both of us that day. Sometimes we do some piggybacking where I might see a patient in 2 weeks and then they see the physician in a month. And so that way we can kind of bridge the gap depending on how acute or complex the issue is that the patient is dealing with. And both of those are billing. Sometimes the billable services, the initial consult and the follow-up. Follow-ups, oftentimes we want to try to keep those 15 to 30 minutes. And again, sometimes I admit that I'm not always great at that, but that's kind of the model we try to adhere to if we can. We also can do psychoeducational groups. So this may be condition specific, doing a chronic pain group. The nice thing about that is a lot of the things that we are doing with patients, we're saying and doing the same thing, right? There's not, 500 different behavioral health interventions. Somebody has insomnia. How many of the patients in your clinic have insomnia? Maybe it'd be helpful to have an insomnia group where you meet for 6 weeks and you have one, an hour a week for 6 weeks, whatever the model might be, where you're teaching them behavioral management of sleep, right? That's going to be more efficient than seeing, 10 different people 6 times. So oftentimes psychoeducational groups can be more efficient, and you have the added benefit of the patients can learn from each other. So that's another, and it's enjoyable if you like to teach, so it's an enjoyable role for some folks. We also can do telephone consultation. So sometimes we do check-ins. If somebody's in an acute crisis, we may see a patient, let's say somebody, and again, we'll look at mental health, not to focus on that, but let's say somebody is in suicidal crisis, you see them, they contract for safety, and we'll talk about kind of the pros and cons of contracting, but they agree to not harm themselves. You have a safety plan in place. You're going to see them next week. Depending on the acuity of the situation, you might call them a day or two later just to make sure that they're still doing okay, that they're following with the plan. So that's one example. Or somebody was just recently diagnosed with diabetes. Overwhelming. If you've ever worked with a patient who was just diagnosed with diabetes, they're like, it's like a flood of information that comes at them of, you need to do this, 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 and this, and this, and this, and this. And so sometimes you check back in and say, did you get all of that? Or do you have questions about that? It doesn't have to necessarily be the behavioral health consultant that does that. Sometimes it's the RNCC or somebody else, but that's one of the roles that we play, is that telephonic consultation with the patient, just to check in to see how they're doing with behavioral recommendations or with their treatment regimen. Helping with care management. This could be helping coordinating care. We've talked about that within the context of coordinating care with outpatient mental health, but you might also play a role of coordinating care with other resources, making sure, again, we're looking at treatment adherence. Did they follow up with the referral to sleep medicine for sleep apnea? Did they follow up with the referral to the oncologist? We could help coordinate that. If they didn't, we could try to problem solve, try to help them come up with a way of processing that. Let's say they saw a specialist, and I've had this happen where a patient does see a specialist, their notes aren't in our chart, right? And so if I've seen the patient and they haven't seen their primary care provider yet, or they're gonna see them soon and the notes aren't in there, it might be my job to reach out to that specialist, say, hey, can you send over the information? We don't have that yet, so that the physician will have that, or the provider will have that when they see the patient the next week or 2 weeks. And telemedicine, that's kind of a new area. We don't practice that at St. Charles, but there are clinics in rural areas where this becomes a vital part of care, where patients live in outlying areas. They don't have easy access either for transportation or just distance. And so setting up a system of communicating through HIPAA-secured, HIPAA-approved devices where you could communicate via video conferencing or something like that to help manage some of these conditions. So some of the modalities that behavioral health consultants use to bring about behavior change, usually action-oriented treatment models. So this isn't smile and nod therapy, right? And I've had patients, not to discount that, I've had patients where that could be very helpful for them, but I've also had patients say, you know, they don't want to see a behavioral health consultant. I went to a therapist before and all they did was just and so kind of supportive therapy, which for some conditions I think can be helpful, but they're like, they didn't really help me do anything. And so we really try to focus on action-oriented type of therapeutic modalities that will help them engage in self-management. So cognitive behavioral treatments, motivational interviewing, figuring out you know, what is their interest in making behavior change and what are the barriers to engaging. Working on treatment adherence strategies, working on problem solving, goal setting. You know, those oftentimes are important components of managing behavioral health issues. Reinforcement of patient engagement. I find that really helpful. So when patients do make changes, I really try to reinforce that. You're doing a great job of doing these things. Because I've seen folks that they're like, oh, you asked me to do X, Y, and Z, and I did X, but I didn't do the other things. And they feel bad about that. So like, well, let's focus on the fact that you did X. That's awesome. So I try to practice what I preach, and I'm trying to reinforce positive behavior change, because I think that's valuable in terms of helping with engagement. Behavioral activation, kind of a psychobabble term for, we see this particularly with people who are depressed, but we also see with people with chronic health conditions that they just stop doing stuff. We see this particularly with chronic pain. I hurt, so I don't do anything. I stop working, I stop socializing, I stop doing my activities, I stop doing my hobbies. And so what are you spending your time doing? Well, I hurt all the time, so I'm sitting on the couch watching TV. Not very good pain management, right? I think we could all agree on that. So we might work on strategies for how do you start increasing engagements, increasing that circle back out so we can try to improve quality of life. Acceptance and commitment theory and dialectical behavior therapy, those are both kind of what are called new wave behavioral therapies that incorporate mindfulness strategies. So really trying to incorporate both doing and being. So a lot of times change is not about doing something, it's about acceptance. Right? You know, there's some things we don't have power over that we can't change. So accepting a health condition. You know, how many times does a patient go to their doctor and they want their doctor to fix their chronic condition so it doesn't exist anymore? Well, we can't always do that. We can work on behavioral activation, behavioral strategies to help you manage it, but we also have to work on that cognitive component, that acceptance-based component of being able to sit with that condition that you have that's not going to go away. So we're going to look at this concept of what's called a warm handoff or a warm handover, and what that means and what that looks like. One of the vital components of this is having what's called open access scheduling. So as a behavioral health consultant, one of the reasons why co-location doesn't work very well with this model, if you're purely doing a co-located mental health provider, is within 6 months that patient or that provider is full. And I was in that model. So I worked for 7 years in this integrated behavioral health model. Prior to that, I worked at a hospital system as a co-located provider. And once you're full, nobody can see you. So you can't do a warm handoff because you're seeing patients all day long. So what open access modeling is really about is creating a template for your daily schedule so that you are available more often than not. So part of this brief intervention model is you see somebody a handful of times rather than seeing them every week for 2 years, 5 years, right? And part of this is having the briefer appointment model, the 15 to 30 minute appointment times, and then having open access modeling. So those three components seem to help facilitate this model, particularly with warm handoffs and same day access. And so this is just a model of what this might look like. So you might kind of alternate throughout the day. You might have new patient or follow-up appointments on the hour, and then on the half hour have same day availability. So in this kind of scenario, the longest a patient may have to wait is a half hour, unless you get in one of those situations where you have 2 providers trying to refer somebody to you at the same time, which that can happen too in a busy, fully integrated practice. But it's kind of nice to be able to do that, to say, you know, I have availability at this time. It also gives you some flex. Let's say a patient comes in and they arrive early and you knew that the provider wanted you to see them. It's like, well, I have a patient in 15 minutes. You're not scheduled to see them for a half hour. how about if I see you right now and I'll just kind of bump my patient by 15 minutes because I have some flex in my schedule to do that. So I can see them for 30 minutes, they go see the doc, so you're seeing them before the provider. So that's kind of a nice model that you could do if you have this flexibility. You'll also see in this kind of model that administration time is built in because when you're in this fast-paced kind of model, when you're seeing lots of folks, you also have to have time to do those consultations with the providers. You also have to have time to make phone calls. You also have to have time to finish up notes and things like that. So oftentimes in these models, open access models, there's some administrative time built in so that you can achieve that. So as I was mentioning, that this warm handoff concept is really the hallmark of an integrated behavioral health primary care model. And what we're trying to do here is having the healthcare provider, physician or advanced practice provider work collaboratively with the physician or with the behavioral health consultant. So we don't want a model where they just say, hey, come in and see this person. Oftentimes what's happens. What would be better is if you bring in the behavioral health consultant in the last couple of minutes of the appointment, say, hey, this, and Kim will talk in just a little bit about these communication strategies of how to facilitate this, but just from a kind of a what this model looks like on the surface, it's like, let's bring the behavioral health consultant in the last couple of minutes. Hey, I want to introduce you to this other member of our team that I think can really help you with some of your health conditions. We're going to talk a little about this, what's going on with this patient. The patient hears this, right? The patient is in on this conversation. They can say, oh, well, that's not exactly right. There's this, that, and the other thing. And so they're seeing that you're working as a team. So if the values and the team is the most important part of the intervention, might be helpful for the patient to be able to see that, right? That you guys are working as a team, that you know for a fact that you're coordinating with each other because they're hearing it, they're seeing it in the room. And so this kind of model helps facilitate communication and make sure everybody's on the same page. Like I said, you can get correction from the patient, engages the patients and families. They could ask questions. So what is it you do? Why am I being sent to their shrink? If they kind of fall back to that, we want to try to avoid that kind of language, which we'll talk about in just a little bit. Correct information, and it builds the relationship. So you are trying to co-opt the relationship a patient has with their provider. When you are the primary care provider, that's who they're coming to see. That's the relationship, the primary relationship they have. They have chosen that clinic because they like their provider ideally, and they like the provider they're working with. They don't know you as a behavioral health consultant. And so you are relying on that relationship that the patient has with their primary care provider to legitimize what you have to offer and to legitimize that you are a good person to see. And so for them to actually witness that in the room, the collaborative interaction is very helpful.
This is where language matters. And really, oftentimes, we'll just say the primary care provider is the first contact for patients in the clinic. And the idea behind this is you want to increase your hit rate. So this is where language matters. And you also want to decrease the amount of time that you're spending on that referral or engagement process. So you really want to avoid using words like mental health, therapy, therapist, counselor, and professional titles. When you start going down the road of introducing your team member in that way, it's setting it up for something we're not actually going to do, because we don't do therapy or counseling. We don't do that. And really, we want to be introduced as a part of advanced primary care, right? This is just another option for your care. And so once we're in the room, we all have an obligation to go through informed consent. So we're going to tell them who we are anyway. So, and we like to use our language to set the stage for how we're going to participate in their care. You don't want to imply that there's a long-term relationships there. In fact, one of the fidelity standards is that we see patients for 6 sessions or less. That's what we as fidelity for an integrated care model. And now some of those patients are going to be hangers-oners. There's about 5% across the nation that hang into primary care, and that's normal. But overall, we want to be able to see a high amount of patients. And we're not designed to do therapy or counseling. We're really designed to do short-term consultation as a part of advanced primary care. So here's some examples of what you might say. And lots of people have published these, but you're going to see in here that it's very neutral language, and all of it's the truth. So you don't have to feel like you're stretching, and I'll just go through one. It says, in my experience, patients with your symptoms do better when I bring in our team members. We'd all work with you to turn this around quickly as possible so you can start feeling better. Does that sound like something you'd be willing to try? And if they do you have time right now to insert Fred? Do you have the right time? Even just to say hello, do you have time? And you can see all of that's true, and none of it implies a service that we're not going to have, that we're not going to do. I would say that our BHCs in the room, you have an obligation to make sure the patient's engaged in their health. And you're in the record reviewing anyway. And so if they are not doing what they're supposed to be doing, you also have a responsibility to increase the hit rate of proper engagement with primary care. So you absolutely, if you see they haven't been coming in like, hey, your A1C was scheduled on this day and I didn't see that happen for you. Let's see if we can get you in with your provider or the lab to get that taken care of today. So you can see that transdisciplinary approach play out there. In our training, I know I had a very long career in medicine, and then I went into mental health. And I know as a mental health provider what I was trained to do. I was trained to get down to that nugget, that tiny little nugget, that pearl of wisdom with a lot of detail on what makes this person tick and do what they do. And my explanation for that would be very lengthy. You see that in a lot of psych reports when we do testing, they're like 20 pages long. That is just not, that becomes a language barrier in primary care. You don't have, most of our primary care providers don't want to know that much. It's not germane to the healthcare you're providing, and you don't have time. So there's lots, we want to provide feedback. So ideally, you'll see us circle back after the end of each appointment. We want to give it, but one of those standards is we're giving feedback either electronically or face-to-face 100% of the time. For those of you interested, there's lots of team-based care communication approaches that really help facilitate the best of team-based care. They're all effective. It's just a matter of what your team, I usually use SBAR. Those that work with me on when I am doing clinical care know I give SBAR, which is situation, background, assessment, and recommendation. I use that fairly standard in my feedback to providers. I also do that in my note. I pass the baton is another one, and that's an acronym as well. Either are very effective, but I would recommend, because you have so many disciplines on the floor now, that you choose one, and as a team you adopt that as a way that you communicate and bridge those communication differences that you have while you're on the floor. There's informal strategies as well, and you can use those as well, and they're just as effective, but important to have common language as a team. The nuts and bolts, how do you do this thing, right? So what organizations do pre-visit planning? Most MAs do pre-visit planning before the day, but as a team, who's doing pre-visit planning? Few people are raising their hands. Okay, that is a key time where you start to identify different team members and you can start planning for the day, right? South Central Alaska does this very, very efficiently. They do pre-visit planning in huddles, and part of that huddle every day is, and usually what they'll do in pre-visit planning or huddles is they will just fill those same day slots. This patient is totally appropriate for your care today. And they start just talking about the divisions of labor of who's doing what. If you need a CHW, BHCN, and RN, or multiple team members, who's going to focus on what and how we're going to get back to each other on the outcome. And chart scrubbing is another way. And every team member should be looking at each other's schedules and start looking about how you can efficiently use each other throughout the day. And if you're population-based, we've moved to registries, right? We're using registries. You've got an X amount of patients with an A1C of this, and we're going to start thinking about team-based approaches based on that, on what you see. I encourage everybody to think really strategically, right? At a federal and a state and CCO level, and primary care performance, and we're incentivized through meeting certain quality metrics. So when you're in a huddle, you're doing pre-visit planning or you're chart scrubbing, I encourage everybody to have a trained eye towards those quality things that you're trying to accomplish from a team. And so, for diabetes, for patients with an A1C of 8 or greater, hypertension, 140/90, obesity in both in peds and adults, and pain. Anything that we're on the hook for performance, that's where we can deploy team members most effectively. And you can train MAs to look at it that way, like anybody with an A1C of this or greater, I want you to make sure it's on the BHC schedule. Anybody with hypertension of this or greater, I want you to make sure you're using this team member for. And that way, we're measuring team-based efficiency on that quality metric. And that's really the goal of advanced primary care. So you want to think strategically of utilization. And these are just some other examples of how you can train your team members to think strategically about how we're going to deploy our team members.
Yeah, password. So so these screening tools and pre-planning that she's talking about, it's a good way to automatically put folks on the schedule. So it takes it out of that multidisciplinary to transdisciplinary, where again, we talked about this model where the physician is in charge and they determine who gets referred on to the behavioral health consultant, which still is a little bit of siloing of care. So if you do a pre-huddle or screening like this and you identify these folks and just plug them in automatically, I think that's a good way to coordinate care. What we're going to be talking about next is some pathways of care. So we took a couple of examples, like I mentioned at the beginning, both Kim and I, and one of the things that we really have a passion for is program development. And so especially when we were first starting the program and trying to get things up and rolling, when we had downtime, we try to develop programs of care around various health conditions and figure out how to address those. And so we're going to talk about a couple of those. We certainly have other ones that we've developed over the years. So if you have questions about those or want access to those, Kim or I could probably provide those to you, at least things that we've tried. Not that you have to do it our way, but it just kind of gives a template for the way you might approach that. One of the first ones we developed was a diabetic intervention model. And so we looked at individuals' diabetes. How do we want to refer those? So hopefully, did you guys all get handouts of these? The print on them is pretty small, so we try to get handouts for all of them. And so let's say a patient comes in and they're either newly diagnosed with diabetes or it's a follow-up appointment, and we're looking at their A1Cs. And so we would look at, is their diabetes adequately managed? If their A1C is below 8, nothing you need to do, just treatment as usual. They're managing their diabetes, probably doing okay. If their A1C is above 8, if it's not well managed, then we will implement, for example, a 4-week diabetic education class. So again, to optimize, it's not like there's only a few people in your clinic with diabetes, there's probably hundreds of them. So just from an efficiency standpoint and optimization, we might have them plug into a diabetic education class that includes the behavioral health consultant, clinical pharmacist, the RNCC, we all have our areas of expertise, and so we could provide some education and training to help them manage their diabetes better. They might also follow up with the RNCC. Do they understand the medication instructions? Do they understand how to do the injections? We had a patient in my clinic that they kept increasing the insulin dosage, and their A1C kept going up and up and up. They finally met with the RNCC, and they found out that they weren't taking the cap off the insulin. So they were like injecting it without actually injecting it. So once they did that, they were significantly able to reduce the dosage of their insulin, and actually were able to get their A1Cs under control. But again, it was a health literacy issue. The individual didn't understand how to inject the insulin, and the RNCC played a very valuable role in helping them with that. We look at whether they have depression or anxiety. So one of the things we routinely might do is screen for depression and anxiety using the PHQ and GAD. If those scores are elevated, in addition to or after the class, we may have them plug in with BHC one-on-one and work on addressing that until we could address that component, because we know that depression and anxiety affects diabetic management. If a person is also on psychotropic medications, particularly if they're on more than one, and their scores are still not under control, we might want to refer them to the consulting psychiatrist so they can take a look at their psychotropic regimen and see if we could optimize that. If a patient is taking 6 or more medications, so that never happens, right? So as we talked about earlier, oftentimes individuals with diabetes also have multiple other chronic health conditions. That might be a good opportunity for them to meet one-on-one with the clinical pharmacist, if you have one, to review their medications and try to optimize that, because the more medications you add, the more risk of drug-drug interaction effects, and the more complex and the least adherence to the treatment regimen you might have. This was a later development that Kim Swanson worked on as part of a fellowship program, is complex care management. So there's actually federal funding for complex care management of patients who have more than one chronic condition, where that condition is likely to cause significant impairment or possible death. And so with these folks, we really want coordinated care to help manage that. And there's different ways of doing that, but in the model that Kim developed, it really involved primarily behavioral health consultant. We're doing scrubbing of the schedules. We're identifying people that are coming in for an annual wellness visit or an NM evaluation, and we look at their chart. They have multiple health conditions. They're causing a lot of problems. We're going to let the physician know that, so that they could talk to the patient about a possible referral to the BHC, refer over to the RNCC to help with management as well. And with this complex care management program, what we might do, you have to have 20 minutes of non-physician face-to-face contact per month, and then you get a per pair per month reimbursement. And so as part of that, one of the models that she developed is having a monthly class that was led by the BHC and the RNCC, and I think the clinical pharmacist, CHW, and the pharmacist. So kind of a team-based intervention once a month, where they'd come in and that would meet that need. If a patient didn't show up for the class, then they would do a phone consult with them to meet that non-face-to-face component. And then they have to have kind of a shared care plan that is approved by the patient. So it's really not only collaboration among the different providers, but collaboration with the patient on their care management program. Okay. So we also talked about chronic pain management, and we didn't put up the workflow here, but basically just want to emphasize that when treating chronic pain, this is an area where we absolutely need integrated management. There's very little data showing that medication management alone is effective at managing chronic pain. That's where we came up with this, they've come up with this biopsychosocial model of pain management, where you're really addressing all of the various variables and factors to help manage chronic pain. And so this is why we make the argument that anybody with chronic pain should have contact with a behavioral health consultant. Particularly if they're on opiate medication, we want to make sure that they're seeing a behavioral health consultant, so they're not just relying on medication for managing their chronic pain. This gets into a really touchy area with chronic pain because, you know, a lot of folks with chronic pain, they've been dealing with it for many, many years by the time I've seen them. When you suggest they see the behavioral health consultant, they'll, you know, the reaction is, well, this isn't all in my head, my pain is real. So you're really trying to address that. I've gone to a number of national and state chronic pain conferences, and they're actually talking about switching this to more of a psychosocial biological model rather than a biopsychosocial model, because they're finding that so many of these psychosocial determinants play such a strong role in somebody's capacity to manage their chronic pain. This is the one I was talking about earlier. So this was one of the first models that we developed way back when I was working in Redmond at St. Charles Clinic there with Kim. That's where I started. We had a couple of pediatricians there and really wanting to try to address pediatric obesity. And so with this model we developed, we got some grant funding from the St. Charles Foundation to buy or to put together pamphlets and workbooks for helping families manage diabetes. Because one of the things that we know is, obesity, sorry, it's getting late, late in presentation. So one of the things that we know is that if parents are obese, the likelihood of the child being obese is significant. We know that if a child is overweight or obese, their risk of having health complications in adulthood is substantial. And so we try to develop a pathway of care for addressing these folks as a family. You're certainly not going to just work with a child to manage pediatric obesity. So we developed this program where if a patient is identified by the pediatrician as being in a high-risk group because of their family or because of their own weight, that we would recommend that that the physician talk to them about this coordinated care with the BHC and the RNCC. And in this model, if, you know, certainly the patient could decline to do that. The way this lays out, I apologize for the formatting here, it kind of rolls down there and then up here. The way the model works out is if the patient or a family declines to meet with BHC, we still want to, it's not a one and done thing. You don't say, well, poor kid, we're just going to let them kind of do their thing, right? So we still want to check in periodically with the annual wellness visits and things like that to see, because motivation changes, interest in making behavior changes over time. So we want to try to give them as many opportunities as we can. But if they do agree to participate in the program, then what we do is we start with kind of it's kind of a step process where they're going to meet with the behavioral health consultant. The workbook that we have has various areas of health functioning. So, you know, it's not defined as an obesity management workbook, and that doesn't go over very well with families and kids. It's a healthy workbook. And so we look at, you know, how much TV are they watching? How much sleep are they getting? What do they have for breakfast? Do they understand labels on boxes? So it's like, oh yeah, I have a pretty healthy breakfast. I ate Cheerios. Well, what kind of Cheerios do you eat? I eat the honey nut Cheerios. You know, there's going to be more sugar content to that. I'm pretty healthy. I don't drink soda. Well, what do you drink? I drink Gatorade. Right? If you've ever looked at what's in Gatorade, very high sugar content. Keep in mind, Gatorade was designed for football players in Florida in 95-degree weather. The average person doesn't need to be drinking Gatorade. But I've seen patients that they feel like they're being healthy by making healthier choices. But part of this process is working with them on health education about weight management. Are they getting exercise? Pediatric recommendation is an hour or more exercise a day for children. You know, are they getting any exercise? How much time are they spending playing video games and things like that? And so we have kind of a broad range of areas, and then we want to allow the family to identify, or the patient or the child to identify, where do you want to start? What would you like to work on? What would be a good starting point for you? So they have buy-in to it. And then we monitor that. So we monitor, are they making changes? Have they demonstrated some improvement in how they're functioning? If they have, then we might move on to another topic area. And then, as I was saying, it's kind of graduated. So we first might meet with them every 2 weeks. So as behavioral health consultants, we can do that. They might meet with their physician every 4 to 6 weeks. So it's saving the physician some time or the provider some time to see other patients. We're seeing them more frequently. We might have the RNCC or the MA calling to check in to see how they're doing with this on a weekly or bi-weekly basis. And then as time goes on, we may expand that out to once a month, once every 6 months, things like that, as they're demonstrating improvement. So again, just another model. Last thing I want to finish up with, and we're going to try to save some time for Q&As to try to address any questions you might have. We also want to talk about shared medical visit. This is kind of a unique model, and well, yeah, in terms of implementation. So I know that we don't implement this at St. Charles. Have you guys done this at Mosaic? We're still working on it. So it's been around for a while, but in terms of implementation, I'd say it's relatively new. It's basically working on a group intervention model, so an integrated group intervention model. So you might take a population of patients, let's say diabetic patients, chronic pain patients, and you have them meet with a physician and various other support providers, BHC, RNCC, various folks like that, where you have an opportunity to do education, provide information in a group format. You will also check vitals. You might have the patients pull out one at a time to check vitals or to answer any one-on-one questions with the physician. And it's just really kind of a neat model for actually optimizing efficiency for physicians. So they get credit for seeing all of the folks in the group because they're going to see them individually, but also frees up time for them to see other patients through the day. And one of the reasons we want to have behavioral health consultants involved in this is because we do have training in group management. So in any group, you always run the risk of having folks that are monopolizers or complainers or things like that. And so as behavioral health consultants, we can try to help manage that so to help the group run efficiently. And they've done some research on this model, and what they're finding is that patients often like it, and they do better. With certain patient populations, you might see reduced utilization of ER or urgent care. You might see better A1C scores from this involvement. They feel more connected to their providers. You also see greater patient or provider satisfaction. They enjoy having that kind of interaction. It's kind of a break in their day. So rather than just seeing patients every 15 minutes for 8-9 hours, they may take out a couple hours to do this group intervention and then do the brief interventions outside of the group with that. So it's kind of a nice way for them to break up their day. I talked about that. So patient satisfaction and provider satisfaction with this kind of model. And then here's some of the conditions where this has been developed for and had some success with. So again, kind of situation specific is the way the group is set up, or condition specific. And here's some resources that you could access if you want to look into this model. It's a pretty interesting model, I think. So, all right, so we're about 10 minutes to 9. And just wanted to give you guys the opportunity to ask any questions you might have about what we presented. We covered a lot of material. So open the floor for you guys.
I would wonder about high deductible plans and patients having to pay so much money every single office visit, so they really count on coming to be seen once a year. If that's covered by their insurance companies, then what they see.
So the question is around the high deductible insurance plans, and those patients are billed for every patient visit. Yeah, I think that's a population where team-based care is definitely struggling and really hard to administer. I don't have a lot of super awesome solutions outside of sliding scale fees and things like that in order to make that happen. I think the greatest amount of payer innovation has happened in the Medicaid space, where that really has allowed us to do team-based care at a high functioning way. In the commercial space, there's been a lot of lag in payer reform and how to really help that happen. And I think those on those high deductible plans are probably suffering the most. Medicare is another one, what I would argue, because they don't reimburse for group visits. So if you're looking at a group visit model, then Medicare patients really suffer as well. And this is part of one of those barriers to high functioning team-based care, because we really want to be payer blind as clinicians, but we're not really in a position to be payer blind. So I'm sorry I don't have a more thoughtful answer other than to validate and say outside of a sliding scale fee, I'm not sure how to approach the group that easily. Any other comments or questions? Yeah. Oh, wait, we'll go Mark and then Lindsay. Mark first.
But the other piece is the patient the impact on like our patients come in, they expect to see first.
Yeah.
And I'm wondering about managing that area of the patient's time quickly or after a lot.
So I'm going to say what you said, try to paraphrase what you said to the rest of the group here. And it really, first was a comment of the idea of registry-based care is really exciting because it takes it out of that referral-based thinking space. And then the other comments were really around patient time. And you said one other thing, say it again. Insurance. Okay, so let me address the insurance piece first. I think there's a lot of complexity attached to the referral, and I don't need. There's maybe 2 insurances where behavioral health does need a referral, but other than that, that's not a requirement for reimbursement for us. However, there's like some that do. So you can do that on the back end if you go into a registry. I think that's one of those workarounds and some of that. Time is an issue that I hear a lot. But I would argue, and yes, you're going to extend the patient's time with a team-based care approach that day. And potentially moving forward, you might be adding time. But I would argue by doing it a different way where it's disjointed and you're having the patient come back, or you're not planful and you're searching around for a team player for a same-day visit, your time is way, way, way greater on that patient. If you're planful in that morning and say, I think this patient's going to need to see this BHC that day, and you just put them on the schedule and it's already planned for by the team, you're going to decrease that time in the clinic for the patient by an hour. Yeah.
So just in complex care, one of the things that we're starting to do more of is that when we see the more clinically complex patients that have a lot of working parts, I'll call the patient ahead of time saying, I see you have a primary care office visit. I'd like to be a part of that office visit along with the nurse care coordinator and the MA. We'll all come in during that 20-minute visit and have a conversation, because oftentimes the patient's questions, 3 of us can answer it differently, or we can do the care plan right then and there. And so we have basically family care conversations during the patient office visit. We've done that just for about 6 or 7 of our really complex patients, and they really appreciate that. Can I answer your question?
Yeah, I'd like to do that. It's
Yeah.
hard to structure. And I think a lot of it is getting people spend so much time trying to be great.
And some clinics work on permission and some don't. And I can tell you, I've worked in clinics where they don't ask permission. And I can tell you, and everybody worries about how the patient's going to respond. They've responded fine. Like, I've been in high performing teams where they just put them on my schedule and patient permission is secondary to that. And in essence, it's my job. If they don't have time or if they don't want to, then we'll just take them off my schedule. It's not a thing. And so that shouldn't be the barrier to making the team function at a highly effective place.
Another thing I'd add is how often does a patient see their primary care provider and they recommend labs? And so they see, I'd like you to do these labs before you leave. So we have to think about it differently, because if we're asking them to do labs or other things during that appointment, and that's okay, but referring to behavioral health consultants not okay, there's a bias there. The other part of this is where infrastructure and education becomes really vital. So if you're creating a clinic that is based on team-based care, and you provide adequate training and education to the patients that this is how we operate. We have a lot of folks here that help you manage your care, and so on any individual visit, you may see, different team members, so they're aware of that ahead of time. I think that can help facilitate it, but it requires a lot of infrastructure development and education to achieve that. And I think that becomes a barrier for a lot of folks, is that infrastructure and education hasn't been done for yet.
Lindsay? This is the first question. I'm sorry, I don't know. But I would have found that it's been helpful in the efforts. So we're having more well-health checks on quality things. One is something that adults may get from but I do see when you plan ahead of what's this person have in let's capitalize on it and see the VHC today. And then that also helps offset them having another coping. So I think that morning huddle and maybe even just accepting for us as providers, like that maybe that's my one-time shot in the clinic, and I'm doing a phone call, 4 weeks. To me, that's gone a long way in that I'm considered of their financial barriers, and we're going to capitalize while they're here, and we're going to do the best we can.
Oh, yeah, no.
One other thing that I'd add is that in primary care, patients always come back. Right? Especially patients with chronic conditions. That people with complex chronic conditions don't often just be seen once a year, although that does happen. But one of the things we see in primary care is patients do come back. And so if there is a barrier like that, sometimes I'll just say, well, can we set this up for the next time you come in? Because that condition is not going to go away. So you can just kind of optimize it that way so they're aware of it for the next time.
And I think too, you're seeing when you have that care team hit that initial visit, there's so much more value there that will move best.
And she said if you have the care team present and seeing the patient in that initial visit, the patient engagement investment goes up. We have about 1 more minute for questions or comments. I just want to end with something I'm supposed to say that's buried in paperwork somewhere. I think it's a reminder to fill out your evaluation forms so that you can get your CME today. And I just want to leave with this thought. How you choose to do this is fine, no matter what you decide to do. Just decide to do it, right? The only thing that I will say that would be not a good idea is optimizing your team members to their fullest capacity. How you do it is perfect. Did you have a question in the back? Okay, you're just resting. Okay, so thank you so much for your time and your attendance and attention today. Very grateful, and we'll see everybody in December. Thanks.